Good evening, everybody, and welcome to Prostate Forum. This is kind of an unusual video for us in that it is being filmed on April 1st, 2025, instead of our usual fourth Thursday. But we are fortunate and honored to welcome back Dr. Jeremie Calais, MD of the University of California at Los Angeles, Theranostics program. He is going to tell us tonight about cancer molecular imaging, nanotechnology, and theranostics. And for those of you who are not familiar with Dr. Calais, who has been here before and is always very interesting, he is Associate Professor, Department of Molecular and Medical Pharmacology at UCLA. His work focuses on improving cancer treatment outcomes using novel diagnostic therapeutic approaches, meaning a lot of this is in development. He uses PET-CT imaging for cancer phenotyping, radiation therapy planning, therapy response assessment. He leads UCLA's clinical theranostics research program that integrates radionuclide therapy with imaging.
Thank you very much. My pleasure to be here again. Today I will talk about PSMA targeted theranostics and imaging and see a bit and provide an update on all the upcoming clinical trials. So I'm going to share my screen. Let's do this. Please confirm you can see the slide.
Yes.
Okay, great news. So we can use imaging and PET-CT imaging for prostate cancer staging and restaging at different disease stage of the prostate cancer patient journey. At initial staging, to make sure the disease is still in the prostate, or if it has gone beyond the prostate in metastasis. If patients are unlucky, there is recurrence, and then you need to know where the recurrence is coming from. You detect it by PSA, but you need to know anatomically where it is and quantify the volume as well visually. And then in patients who are getting treated and retreated with multiple lines of systemic therapy, you can restage to evaluate the volume of the disease, the therapy response assessment, and ultimately also you can maybe treat with PSMA targeted radionuclide therapy. And for that, you also need to do the PSMA targeted PET imaging for target expression assessment. These are mostly the big boxes, but in fact, there are many more. If you want to do a refined categories, we can also go beyond these categories. I will briefly mention that. Just to make sure we're on the same page, there are multiple ways to do targeted PET imaging of prostate cancer. Before, we're using mostly bone scan and fluoride PET because the tropism of prostate cancer is let's say, largely in the bones. You have the lymph node metastasis and the bone metastasis, which are very frequent. And so with the targeted PET imaging of the bone reaction, the osteoblast, you can indirectly image the prostate cancer metastasis by looking at the reactions surrounding them. Then you have the metabolic activity of the prostate cancer cells, FDG, choline, fructose, glucose, phospholipids, protein metabolism. This can be used. Not so long before, fructose PET was still the standard of care in the US for staging prostate cancer. And PSMA, Prostate Specific Membrane Antigen, is a cell surface protein expression. That's what we're going to talk about today, creating these images here. Now it has been shown to be superior to all the other imaging modalities, whether it's CT, bone scan, fructose PET, choline PET. There is a large amount of evidence showing the superiority both in sensitivity and diagnostic performance accuracy of PSMA PET over the other imaging modalities. The first PSMA PET agent was approved in December 2020. It was done with my colleagues at UCSF. It was an academic approval, but since then, many biopharma industry vendors provide commercial options to get PSMA PET. These are some of the vendors here. There are other comings, by the way, and it depends where you are in the world. This one, for example, is in Europe. This one also is in Europe, but the others are in the US. So it's great now. PSMA PET is, let's say, widely available for 4 years, I would say. This is the data that was used for the initial FDA approval, and that was reused and reused by the subsequent approvals. I was fortunate to be part of these studies. If you look a little bit more in depth of the data, you can see these show these pivotal studies for gallium-68 PSMA 11. This is the pivotal study for DCF-PYL, Pylarify, and this is for post-LUMA, RH-PSMA 7.3, the other also pivotal trial used for the FDA. Basically, they behave the same. They have more or less similar patient population here. You can see that below 1, it starts to drop similarly. But what is groundbreaking compared to before is that below 5, you can really see a lot of disease, whereas with CT and bone scan, you would not be able to see that. My take-home message here is to say that these are fairly comparable. There are tiny differences, anecdotal differences that we can notice. It's unclear if there is a clinical significant difference between these tracers. So my take-home message is that to say that these are fairly equivalent. I want to point out, the limitation of PET, of PSMA PET. When you look at the sensitivity, so sensitivity is the number of patients who have disease detected by the PET imaging on all the patients with disease. You can see that it's 40% at max for pelvic lymph node detection, in patients at primary staging with high-risk disease that underwent surgery. So it means that you still miss 60% of micrometastases in the pelvic lymph nodes that were too small, that you were able to see with a microscope on the histopathology analysis. So why that? Because the detectors, that's physical reason that the scanner cameras, they cannot really go beyond the intrinsic spatial resolution of PET. If the lesion is too small, you can see how the signal decrease little by little over time. The same size of lesion, the same uptake, in the lesion, but you can see how the signal decrease just as a matter of size. It has been shown that, from 2 millimeter, you would see barely 50% of the lesion if there is sufficient uptake in it. And then there is all the disease that you don't see, specifically in advanced prostate cancer. You start to have complex dedifferentiation processes and heterogeneity on the biological level. And so PSMA would show all the PSMA expressing cells, of course, but you don't see the non-expressing cells. Luckily, and that's explained the success, most of the prostate cancer cells express PSMA at high intensity, but there is still some, even at primary staging, that do not. So that could be a limitation. We commonly say that it's between 10 to 15% that do not express PSMA. Now, even when the scan is negative, you still have some value in it. People sometimes are disappointed to have the scan negative because we don't see the disease, but it's good. It means that either there is no disease or the disease is too small to be seen, or very rarely it would be PSMA negative. But in the primary staging, that would be too rare. So here, for example, you can compare in 2 studies, very similar, 2 same group of patients, patient who had surgery, the one who had nodal or metastatic disease detected by PET in red, and the ones who did not had a negative scan. You can see that usually when you have disease visualized on a PET scan, it's already too late for surgery if you intend for a surgical cure. So negative N0 PSMA PET scan does not exclude N1 microscopic disease. A negative N0 PSMA PET scan is prognostic of better outcome after local therapy, and it must not preclude local therapy if intended for cure. I mean that because at the beginning, people wanted to de-escalate therapy. They had no lesion visible, so they wanted to forego whole pelvis irradiation, pelvic lymph node dissection, because they thought there was no disease, but that's not the case. Similarly, in the salvage radiation therapy setting, we can see the same thing. The patients who are doing the best are the N0, M0 patients. These were having positive uptake in the prostate fossa. And if you take this one and you do radiation therapy on them or not, you can see that the one who get radiation therapy do much better than the one who do not. These, in fact, progress because even if the scan was negative here, there was microscopic disease that we couldn't see. So you should still treat if you intend to do salvage radiation therapy, even if the scan is negative. It's actually the best situation to do it. It also redefines now, oligo polymetastatic disease, whether it's 3 or 5, the number we'd use to define oligo. And we also create a new category of patient for negative by conventional imaging for metastasis, M0, but now are M1 by PSMA PET. So we will learn slowly how to treat at best these patients. This restaging effect or stage migration, we observe it in the patient from the EMBARK trial, the patient that led to the approval of enzalutamide in high-risk BCR patients. We look at a similar cohort in our data set, and you can see that these patients who were supposed to be non-metastatic by conventional imaging, well, they had 46% of them had metastasis, in fact. But these patients were still the one included in the clinical trial, so they did benefit from enzalutamide. So it means that slowly, little by little, we need to refine a little bit these categories and learn how to use at best. Sometimes you can have false positive. So one typical pitfall are the ribs. So the ribs are really a common site of little trauma, fractures just by cuffing, just by little hits, a little bruise. This would light up on the scan. You can have fibrous dysplasia or other benign, pretty common pathologies that would mimic a prostate cancer metastasis. So when the uptake is low, let's say below 5, SUV max of 5, that there is maybe something on the CT that suggests another thing, that there is nothing else elsewhere. It's good to be cautious and do not overcall that as a prostate cancer metastasis. Of course, when the uptake is high, such as here, 17 of SUV max, well, even if it's isolated and there is nothing else elsewhere, it can still be a prostate cancer metastasis, of course. There is many cases like this. So here it's, I put that slide because it's good to understand that as a radiologist or a PET-CT reader, you want to, the primary focus you can have is to not miss a lesion and back up yourself in case of pursuit and to not miss something. So you may overcall lesions just for the sake of sensitivity. Whereas in a clinician, it's more how do I treat this image finding, and you want to make sure this is real and not over-treat patient or treat something that is nothing, and more for the specificity. So there is always this two approaches that we need to find a good communication in between. And of course, the patient needs to understand that as well. Another example of stage migration effects in patient with metastatic disease, this time still at the hormone-sensitive space. It's been now a decade and more that patients are being classified in a high and low volume by what we call the Charted criteria. So it's the number of metastatic lesion you can see on a bone scan, 4 or more, or 4 or less, in the axial skeleton. But these categories were made on CT and bone scan. And when you look now in patients who got both the bone scan and CT and the PSMA PET, then you can correlate a little bit how one translates to another. Well, you can see that there is a lot of stage migration effect. Of course, you have upstaging, patients who have more disease on the PSMA PET scan. Patients who are still low volume by conventional imaging are also low volume by PSMA PET. And you also have the reclassification in patients who are non-metastatic because, in fact, the bone scan is not very specific. You have a lot of uptake that can mimic metastasis, but they're not because they're just bone trauma or something else. So these patients, they were shown to benefit from, for example, radiation therapy in the prostate with the metastasis otherwise. We need to know now how to reclassify and integrate that into the new treatment algorithm. So the field is learning that. Let's talk about the primary staging in the prostate. MRI remains the imaging modality of reference, but there is a lot of information you can get from the PSMA PET scan in the prostate as well. There is always an overlap between the two lesions that you see on MRI and PSMA PET, but there is always a part that you don't see on PSMA PET and a part that you don't see on MRI and you see on the other imaging and vice versa. On PSMA PET, you can have a decent correlation of the lesion grade, the aggressiveness of the disease, with the intensity of the signal. When it's above 10, basically, it will be a prostate cancer that is clinically significant with a Gleason grade of Gleason score of 7 or more. When it's below 10, then you have overlap. You can have low-grade lesion, benign BPH lesion, and also very high-grade lesion. It's a bit of everything. So below 10, you cannot use the numerical value to make your call. Below 10, you more have to use visual scoring. And there is the primary score that was generated by our colleagues in Australia, looking at how it looks on the scan, anatomic location, intensity of uptake, pattern of uptake, symmetry, yes, no. Here you come out with different scores when you with an SPV max below 10. And now we use it even for targeted biopsy. So at UCLA, we do it with Dr. Marks, with Dr. Brisbane. We have now an established workflow to target the PSMA positive targets in the prostate. There is a ultrasound fusion device that can superimpose the conc tools made on PSMA PET onto the ultrasound device. And we have a pretty good success rate in terms of getting positive biopsy in a patient who had prior negative biopsy guided by MRI or non-guided. Now, I think the best information you can get on PSMA PET is the longitudinal sequential information. When you have to stage and restage patients in 1 second, you get a very rapid sense of what's going on at the patient level, the metastatic level. Here is a great case of a superb response to lutetium PSMA therapy. That's the baseline PET, and over time you see how the tumor volume decrease. It's not always easy to read, and so now we start to come up with criteria. There is the PCWG4. There are the new criteria using PET for reading PSMA PET for therapy response assessment. There are the RECIPE criteria that I show here, so multiple attempts. People are using it now. This one, for example, is a combination of the volume changes and the apparition or not of new lesions. When you have both increase and apparition of new lesion, you have progression. It means you're not responding well to treatment. When you have both a decrease of the volume, no new lesion, it means that you're probably more benefiting from the treatment. And when you're in between, this is intermediate stage. Message that I want to point out, it's better if you want to do therapy response assessment to use the same PSMA PET tracer, although they are fairly similar in terms of detection, visibility of the lesions. Maybe the quantitative parameters, the SUV, they may change between the two scans. So ideally, you want to have a PSMA 11 before and after, and not PYL and RH. Even though you can still get some information from that, it's still better to have the same tracer. When a patient receive, they are in the hormone sensitive stage, not castration resistant, if you do a hormonal shot, well, the prostate cancer cells are hormonal sensitive. They will shrink, they will die, will stop the progression, you will lose the signal. That's what we observe nicely after 3 months or after 6 months. You see continuously in all the lesions a decrease in signal. So if you want to do a PSMA PET scan and you haven't got your ADT shot yet, do it after, no, do it before, sorry, the ADT shot. If you do the scan after the ADT, you will have decreased signal and you will maybe less see the lesions. Just published this paper recently where we looked at more than 200 lesions that were irradiated with radiation therapy. And you can see it takes time for the signal on PSMA PET to decrease. I would say at least 6 to 8 months. So if you want to evaluate locally a lesion that has been irradiated, you have to wait at least 6 months. Of course, you can evaluate the other areas, but for these specific areas, there might be remaining uptake for at least several months. And in the castration resistance setting, when patients start an androgen receptor targeted therapy, enzalutamide, apalutamide, abiraterone, there are some cross correlation with the PSMA expression and the androgen receptor. And it can increase in some patients the level of PSMA expression. You can see here in this patient more lesions, more signal, more intense. So it does happen. We measure at the whole body level these parameters early in the time window of 15 days, maximum 30 days after the initiation of a new ARDT. But that's not the majority. 75% did not have this effect. So we were not able to find specific features to identify these patients, but that's an effect that exists. But I would say it's variable and it's not the majority. Okay, now that's the presentation I gave last weekend. So I'm happy to reshare it here. It's an overview of all the upcoming major PSMA trial for therapy I found of interest. So I used multiple sources that you should maybe look at if you're interested. ASCO, ESMO, these are big medical oncology meeting, the US, the Europe. Often there you have the trials in progress, TIP, that show the trials that are ongoing, but not the results yet. Clinicaltrial.gov, of course, is the reference to list all the trials. EuroToday is a website of communication on all the GU, so genitourinary cancer related publications, videos, a lot of educational materials. It's very nice. So I use a little bit of that, look at clinicaltrial.gov, try to sort out from 600 studies, and I selected 70 of them that I might find of interest. So you will have the slides, I guess, on the video, so you can use it if ever you want to look at it. This is a common way to display the different treatment, the different prostate cancer stages and their different treatments. So here it's the initial staging, then that's when patient got biochemical recurrence. Here it's they become metastatic or just castration resistant but non-metastatic. And then metastatic castration resistant, they try first treatment, a second treatment, third treatment. Vision, the lutetium PSMA pivotal clinical trial that led to its approval, was done here. Metastatic castration-resistant prostate cancer who failed chemotherapy in first line. So it's second to third line indication. In yellow here, you have some of the PSMA targeted radioligand therapy trials that are ongoing at different disease stage, and I will show that a little. So first, we have PSMA-4, SPLASH, and ECLIPSE. These are the main new impactful clinical trial. Just last Friday, I should have updated this slide. Just last Friday, PSMA-4 was approved by the FDA, and now the FDA has approved the use of lutetium PSMA therapy in metastatic castration-resistant prostate cancer patients pre-chemotherapy. So the chemotherapy is not anymore a requirement. Some trials are trying to compare lutetium PSMA therapy versus chemotherapy. There was this Australian trial, therapy. There is this Canadian trial ongoing. So this will be helpful to know a little bit the sequencing of this treatment, because is it better to do chemo first or lutetium PSMA therapy first? It remains a little bit unknown. But the great news is, again, since last Friday, it's now approved for patients even before chemotherapy. Then the next step will be in patients without even castration resistance. They are still hormone sensitive. They are here the main clinical trial. These are big ones. You can see 2,000 patients, 500 patients. These are major controlled trials that will try to show the efficacy of lutetium PSMA therapy versus a control group in this setting. That's the detailed design of STAMPEDE-2, which is a major trial worldwide, coordinated by London. Patients who have more than 5 lesions, they will be randomized to either get lutetium PSMA therapy, or the control would be NRSI, prostate radiation therapy, and chemo as part of a triplet. And they will get 4 cycles. So this will be a very, very big study. Then you have now multiple trials trying to look at the interest of adding lutetium PSMA therapy in patients who are treated with oligometastatic directed radiation therapy. They have 1, 2, 3, 5, 4 lesions. They're getting radiation therapy there. And in addition, either as adjuvant or neoadjuvant, they get lutetium PSMA therapy. Even earlier than that now, some people are trying in the high-risk localized prostate cancer, treatment-naive, initial therapy, first line, never treated before, either in the neoadjuvant, so before surgery, or in the adjuvant setting, just after surgery. So we start to have multiple trials in that setting as well. Safety is still also, of interest. So Novartis is starting a 10 years, phase 4, long-term follow-up study. Patient will get monitoring every 6 months to make sure, the kidney function, the salivary gland, the bone marrow function, understand better the potential long-term side effect, because the earlier we place the drug, the longer the patient will live. And so we need to understand better the long-term toxicity side effects profile. Currently, it's approved 6x6. It means 6 cycles, capped, fixed. 7.4 gigabecquerel, that's the injected activity every 6 weeks. I think we can do better than that. And now you start to have multiple trials looking at dosing modulation, going to 12 cycles, playing with treatment holidays, treatment interval boost, 2 doses back to back. So multiple trials are trying that now. Many are based on SPECT and PET imaging. So it depends on the response of each patient that we can see an image. So I'm happy to see that as a nuclear medicine physician. It goes one step beyond, individualized medicine. Actinium is the, let's say, next big thing, I think, after lutetium. Actinium is an alpha emitter, so it delivers much more energy in its radiation, and so it may have much more potent effect. You can see multiple trials, multiple companies looking at that now. So it would be interesting to see how this reads out. We have one trial at UCLA, by the way, if you're interested, for patients who are progressing after lutetium PSMA therapy. They can get actinium PSMA at our site. There are even other radionuclides. Here we talk about copper-67, terbium 161, lead 212. So these provide other alternatives to lutetium and actinium. Pluvicto is PSMA 617. It's a small molecule. There is another molecule, PSMA INT. That's the one from SPLASH and Eclipse. But there are also other ways to deliver to PSMA expressing cell radionuclide. You can use antibody, which are much bigger than small molecules. The good thing is that they don't go to the salivary gland. Since J591, that's the main one. It was initially developed at Cornell, and then Telix acquired it and is now conducting a big trial. Here it's just 2 doses, back to back, and then that's it. So we'll see how this plays out, but that's another approach. There is now the category, of course, of patients who unfortunately progress after Pluvicto. It's unfortunately not a cure. And you start to have multiple trials that offer other options for these patients who fail Pluvicto. I mean, they didn't fail, but the disease progress, of course. It can be retreatment with lutetium PSMA, it can be actinium PSMA, or even other drugs. And then the combination. I think the one big thing that will come, especially with the approval of PSMA-4, is the combining an AR-directed therapy with lutetium PSMA. It may be impactful. There is some good data coming out more and more. So that's maybe the next thing coming, is to combine it with Xtandi, for example. People are trying to combine it with chemo. So it may come sometime, and some medoncs may try to play around a little bit with different formula. People are trying also to combine it with immune checkpoint inhibitors to enhance the immune reaction to target the prostate cancer cells and use the inflammation around the radiation-induced damage to better have an effect on the prostate cancer cell. People are trying also DNA damage repair inhibitors as radiosensitizers and enhance the lutetium PSMA therapy effect. People are combining it lutetium and alpha, either with radium-223 or another actinium and lutetium PSMA agents. I think we need or a small molecule and an antibody. I think we need more trial combining lutetium PSMA and actinium PSMA, so I hope that soon they will come. This has been done in Europe, but it has not been converted into clinical trials yet. And I will end on that. So a lot of trials to come. For us as nuclear medicine physician working in the field, it's great, it's very exciting, future is bright. I think we will only progress and give more options to you, and even refine and to better use lutetium PSMA therapy for you. So I will on that, happy to take any questions.
Super. I've had one here from Ira. Does UCLA offer second opinions on PSMAs and MRIs? What is the contact office we should do for, let's say, second opinions on radiology reads? Is what I'm reading here from Ira.
Yes, they do. I can send you the link.
Super. Thank you. Wouldn't it be nice to have is there one database of Theranostics trials worldwide that we can send people to?
Yeah, I'm going to send you 2 links as well.
I think the world has opened up since we last talked to you. There's so much here. I don't remember from the last presentation of standalone Theranostics, first line Theranostics, holidays. I don't think we were talking about any of this a year ago.
No, it wasn't. These are clinical trials. So, and then this one. Okay. 2 additional links.
I'm going to open it up for more questions for Dr. Calais. Anybody with more questions? Dr. Metzger, perhaps?
Yes, thank you very much. That's incredibly complete presentation. We're very lucky to have you in this field for us to help our men. We get a question almost every time we have a Zoom meeting for support. is how low PSA should, or what should the PSA be before you do a PSMA scan after recurrence? Some people say, don't do it till you got 2 or 3 points of PSA. Some say it's more sensitive lower. We had someone who said someone told him copper was more sensitive on a low PSA, but what PSA level do you think is reasonable to get a PSMA scan in a recurrent setting?
It just depends on the level of expectations. So, BCR, it's defined with a threshold of 0.2 after surgery. So that's a fair threshold to start. Of course, the level of expectation, if you do a PSMA PET scan at 0.1, should be lower than if you do a PSMA PET scan at 1.5. You would be disappointed to not see anything, whereas at 0.1, you can expect to not see anything. It happens. Sometimes you can still see lesions, so it really depends on your level of expectations. Now, it's very different in the treatment-naive setting, in the BCR setting. The PSA doesn't have the same value. If you're under hormonal treatment, yes or not, castration, yes or not, the PSA doesn't read the same way. And so the sensitivity of the scan will change as well. In the advanced setting, sometimes the PSA is not, really reflecting the volume of the disease anymore. The more we advance in the disease stage, more often you see patients with low PSA and high PSMA PET volume that's just not expressing PSA. So that exists too. But let's say in the pure BCR setting, just after surgery, 0.2 is a good way to start. And then, yes, the copper 64. So it's not the copper 64 that is more sensitive. It's the SAR-bis PSMA ligand that Clarity is using. This has a dual attach point to the PSMA, so it binds stronger with more signal, so it's more sensitive. That's true. It's not due to copper 64. It's due to SAR-bis PSMA instead of PSMA 11 or PSMA 617. This one is still in early phase clinical trial. I would say phase 2. I think they're studying the phase 3. Personally, I think the data looks great. So I would encourage patients who has maybe a negative PSMA PET scan to go to that study. But this is still ongoing research.
And then I think you mentioned, but could you clarify a little bit about the PSMA guided SBRT treatment for recurrence in maybe the oligous metastatic setting?
PSMA guided, so PSMA PET guided, our radiation oncologists, they use PSMA PET to localize and map the lesions at the whole body level. And if there are not that many, they will irradiate them and monitor the PSA. If the PSA goes up, they will redo a PSMA PET scan. Sometimes you get lucky, you have only 1 or 2 that pops up, you can re-irradiate. So that's something that can, in some patients, prolong the next systemic therapy treatment.
Okay, thank you.
We like to talk about side effects here, and typically this sounds like a relatively side effect-free treatment.
Yes, correct. Especially when you compare it to chemotherapy. It's a drug, huh? It's a drug that you get via an IV line. It gives you radiation, it will create some fatigue, dry mouth in some patients. But overall, when you compare to chemo, all the patients like it a lot. We have to closely monitor it, make it, good. But I think in the next decade, we will probably increase the number of doses and the injected activity because we're maybe still underusing it a little bit, I think.
Did we ever take care of, there used to be a salivary gland damage side effect to this.
Still the case, yeah. So there has not been any progress here. I think the only progress that will happen one day is someone who come up with a new molecule that doesn't go to the salivary gland or less. But in terms of salivary gland protection, you know, we can learn a lot from our radiation oncology specialized in head and neck colleagues, but it's mostly about prevention because once it's there, it's irreversible. With the Pluvicto, it's kind of mild and rare though. With actinium, it may be more an issue. We'll see. But with Pluvicto at the end, all the patients say, yeah, it's a bit dry, but they're okay. I mean, I haven't been treated with it, so I wouldn't talk on their behalf, but we never had to discontinue a patient from salivary gland toxicity.
Outstanding. And this isn't just for prostate cancer, is it? I mean, you're treating other kinds of metastatic cancers with Theranostics now?
With Theranostics, yes, but not with Pluvicto.
Okay.
Theranostics is therapeutic, gnostics, diagnostics. It's the combined use of a therapy and an imaging agent that have the same molecular target. So here we'll talk about PSMA for prostate cancer, but there are other targets, other cancers, but with other agents.
Sometimes we like to keep that in the back of our minds because we all know cancer patients. We all know someone who could be doing better than they're doing. So if it's breast cancer or something like that, let's keep in mind that this is used for other cancers. As the Theranostics is.
Yes, well, you can see on the Theranostics trials and on CDEM Foundation links that I just sent you, you have also many non-prostate cancer applications listed.
Excellent. Bob has a question here. What is the study for phase 3 trial using the copper-based radioactive?
Give me 1 minute.
Excellent. Any other questions for the doctor tonight? We'd like to thank all of you who have joined us live. By the way, if you're watching this somewhere else, watching this recording somewhere else, be sure to get on our website, www.prostateforum.org, and you'll see not only many presentations from many experts around Southern California, but you're also going to see Dr. Metzger's outstanding newsletters with all kinds of late-breaking news about prostate cancer detection and treatment. You're also welcome at our support group meetings wherever you are. We hold them on the second and fourth Tuesday of every month at 5 p.m. Pacific time on Zoom only. We do not meet in person. It's on Zoom only. And you'll find those links both on our website for the support group meetings. And you'll also find that we'll send announcements to you that are hyperlinked if you sign up for our emails. You can sign up for our emails either by emailing me at prostateforumoc@gmail.com. That's prostateforumoc@gmail.com. And or you can sign up on our website under Join Us. But by all means, check us out, get the full benefit of Prostate Forum working for you. Doctor, thank you very much. If there are no other questions, thank you for joining us. Please keep us in the loop, and we look forward to talking with you again soon.
Thank you very much. Bye-bye.
Appreciate it.
Bye.
Good night.